Selby, PGY4. I'll be bringing you our first not-so-small talk of the day. Oh, wait, no. So this is my first time using Prezi. I had a lot of fun with this software, but greetings and special thanks to our Small Talks team. Thank you, Dr. Guy Carmelli, also Dr. Matthew Racinti, and Karen Ties. They were instrumental in helping me put this presentation together. I really appreciate the support and guidance. And now for some more fun and games. Actually, I don't know if I can top Greenstein's act, though. That was pretty fun. But we're going to play a game of differential derby. So we have 4 findings here, physical findings that we're going to go through. What we're going to do is we're going to look at this. We're going to identify the finding, 1, and then we'll have 15 seconds to throw out differentials, okay, for what we see. And with that said, we'll begin. Pretty impressive. All right. I'm not quite sure what her condition was, but let's talk about that case. So 15 seconds, starting now. Throw them out.
Meniere's.
Perfect. Love it. What else? MS. Perfect. Keep going. Keep going. We got 5 more seconds.
Labyrinthitis.
Labyrinthitis. Oculospasm. All right. That's it. Done. Alcohol. Great. All right. So we're going to move on to finding number 2. Okay. Here we go.
Drunk.
Wait, we got the finding. So someone describe the finding? Or ataxic gait. That's what it sounds like we're kind of leaning towards. Ataxia, right? Okay. Now throw out the differentials. 15 seconds. Go. Excellent. Parkinson's. Vitamin deficiency. Keep going. Keep going. 17 hallway? Yes. All right. Excellent. We're done. All right. Great. I like the differentials. And we're going to keep going. And this is finding number 3.
Great movie.
True story. This is definitely me.
See how Peter's into your Nazi box.
Okay, so differential, confusion, basically, right? The finding in the ED, we definitely encounter it a lot. Differential is pretty broad. Everything. Okay, but name some specifics, please. UTI. UTI. Keep going. NPH. Dementia. What else? DTs, no pressure hydrocephalus. Intox, certainly. Dementia. All right. And finally, this is our last finding. All right, excellent. Someone said it. Intranuclear download, right? Okay, excellent. Thank you very much. Wonderful differentials. And actually, I'm impressed with one of them in particular. But putting all of that together, right? If we had a patient with all of those findings, let's say came in totally confused, of course the ACR is not uploaded, you're struggling to get information on this patient, what would be at the top of your list in terms of differential diagnoses for this patient?
MS.
All right. Anyone else? There's a couple of them. Brian, too, thank you very much. And Michael Greisinger. I think you actually said it on the ataxia, the Wernicke's encephalopathy. Basically, that's the meat and potatoes of my talk. No pun, or actually pun kind of intended, because this is a nutritious meal in terms of vitamin B1 deficiency. But we'll start with Carl Wernicke. And actually, in 1881, he described this as polioencephalitis hemorrhagica superioris. This was based on his autopsy finding of 3 patients initially, in which he saw some changes mostly in the brainstem, actually, a lot of these changes that he identified. And putting everything together, he had a case of a young lady, a 20-year-old seamstress, tried to commit suicide by ingesting sulfuric acid and actually developed pyloric stenosis, which down the line led to her developing malnutrition, nutritional deficiencies, and she began to have some of the classic symptoms that we see in Wernicke's, which are ataxia, fusion, nystagmus, or any sort of ocular abnormalities. Actually, the story kind of goes back a little bit further, though. Kanehiro Takaki was a naval officer and also a physician. As the Japanese were sort of getting their might together to go on and conquer the world in the late 19th century, early 20th century, they were having problems with beriberi in the Navy. About 25 to 40% of their personnel were afflicted by beriberi, and everybody was obviously trying to figure this out. And Dr. Takaki actually employed some epidemiological methods that he picked up from some study overseas in Britain and brought that back and ultimately found that this was possibly due to a nutritional deficiency. Basically, he stratified those populations in the Navy and found that the high-ranking officers had very lower rates of beriberi, and sort of prisoners and individuals that were sort of lower ranking had more profound or more prevalent or higher incidence of beriberi. And that led to him saying that, look, this is possibly a nutritional deficiency. Let's change the diet of the personnel. And with that said, he put in recommendations to have them include meat, fish, things like condensed milk, and barley as a substitute for their primary diet of largely rice-based diet. And they actually saw that the rates grew from, again, 25 to 40% down to 0.04% by 1886. So all of this stuff taking place around the same time. These two gentlemen, Christian Eichmann, I think that's how we pronounce it, and Frederick Hopkins, both were the ones that ultimately determined that it was a factor, anti-beriberi factor is what they described it as, that was crucial in the development of things like wet beriberi, dry beriberi, and Wernicke's encephalopathy. And ultimately, these guys were awarded the Nobel Prize for Medicine and Physiology in 1929 for their discovery. And lo and behold, finally, so this is about 50 years later, we finally get to thiamine, right? We identify thiamine as vitamin B1 and as the deficient factor that causes all of these problems. And we just go back to MS1, I guess it was, maybe even pre-med, and we know that thiamine, critical cofactor in some major cycles, citric acid cycle, right, allowing us to get a lot of our energy, utilize our glucose to the best that we can and get all the energy we can from it, but also in the pentose phosphate pathway, things like transketolase that uses this cofactor to help us in synthesizing things like nucleic acids, right, and also supporting our metabolism as well. And with all of that said, this starts to add up and make a lot of sense as to why we see problems where we typically find them with this disease, especially in high demand, high metabolic areas, particularly in the brain. So we actually see here hypoglossal nuclei. We have our vestibular nuclei here. These are actually T1 MRI flare, T1 flare images, MRI. Here we have our facial nuclei, and we see some of the classically involved areas as well, such as the tectum. We have our mammillary bodies, and then finally our periaqueductal gray. And they are responsible for a lot of the presentation or a lot of the findings that we see with our Wernicke's encephalopathy. The confusion, the sadness, the ataxia, sort of those classic things. Now, one thing to really be concerned about, and this is why going back to our initial differential forming is very critical, because we'll only see this triad in 10 to 16% of patients. Okay, majority of patients might have only one of these abnormalities. In particular, ocular findings are the most important. So looking for nystagmus, as you can see, 85% of these patients will present with nystagmus, in addition to other ocular abnormalities. So that's what we really need to be looking for when we deal with these patients. And this is why we need to care. Why should we care? It's not just that this person is confused and we're just going to get them to the floors, right? Because obviously they're going to be admitted. Nobody goes home confused. Well, most people don't go home confused. But basically, this could lead to serious mortality. 20% mortality if you don't get to this diagnosis in time. And if not mortality, we talk about the development of Korsakoff syndrome, which is a more persistent dysfunction, cognitive dysfunction that is irreversible, right? So we're talking about serious morbidity and mortality if we do not get to the bottom of what is going on and implement early therapy. Only 12% of people go with minimal or no deficits down the line. And the cold hard truth is that 80% of these diagnoses are made post-mortem. So we should all be sad because we're not doing a good enough job. Yes?
2 slides back.
Mm-hmm.
You said retinal hemorrhages? That was high.
Oh, no. Retinal hemorrhage is a finding, but 19%. But that's on your fundoscopic exam. We're not going to do that anymore. So look for the nystagmus. Look for the nystagmus. That's what we're looking for in the ED. What the ptosis, right? Scotomata that they might report. That's something that we need to be looking out for. And also, remember, no ocular abnormalities. We still have Wernicke's encephalopathy. So moveon.com. So I got to figure out how to go back and like run through my slides on this thing. But some of the risk factors, right? So we got the in-service next week. We all know the classic question. We're going to have an intoxicated person, a chronically intoxicated individual, right? ETOH reviews are a long time coming in with that triad. But we do need to have our suspicion higher for individuals that might have any history or potential for malnourishment. So everything from cancer, especially gastrointestinal cancers, gastrointestinal surgery, hyperemesis gravidarum, these are all significant risk factors for development of Wernicke's encephalopathy. And case in point, there's a young woman, Honduran woman, that presented basically with, other than mild cognitive complaints and disturbances, just had upbeating nystagmus in the context of hyperemesis gravidarum. And actually, we'll just look at her findings really quick. I know. I mean, nystagmus again. Definitely abnormal, to say the least. And this is pretty much all she presented with, just some mild confusion and this finding of this vertical nystagmus, which is always pathologic, as we know, right? And these were her findings here. You can see her medial thalami involved, also her periaqueductal gray involved. So that's all she presented with, was just the ocular findings and some mild confusion, but in the context of hypergravidarum, hyperemesis gravidarum, we need to consider things like Wernicke's as a diagnosis. That she ultimately was treated with thiamine and had a significant improvement over the course of 4 to 8 weeks, but still had some residual cognitive issues down the line. So the fix, this is the fix, thiamine. Anyone care about the thorough dosages? 500, yes. So actually there's no definitive evidence on the ideal amount of thiamine that we're given, but we want to give as high doses as we possibly can, but safely, of course, right? Normally we give prophylactically in the ED, or when we talk about our intox patients that we're admitted 100 milligrams, but this is high dose, 500 milligrams, particularly intravenously. Intramuscularly, not as effective, and orally, definitely not as effective because these individuals, as we said, have problems with malabsorption, especially in alcoholics. They have liver dysfunction that prevents them from absorbing via the enteral route. And so that's why we need to go IV, high dose. Usually about 1 dose per day, but recently there is some literature to support increased frequency of dosing because of the short half-life of thiamine. It's only about 90 minutes, the half-life. All right, and with that said, we will move on to our take-home message. So major points from this presentation: 80%, we're doing a poor job, I would say, in diagnosing this antemortem. So we need to work on that. And only 10% are going to present with the classic triad of ophthalmoplegia or any ocular abnormalities, the ataxia and the confusion. So we need to have a higher suspicion. Anybody with any of those abnormalities, that's the point of our initial exercise. All of those differentials for any of those findings should have included Wernicke's encephalopathy. And that's the key is that it's reversible, right? Reversible. We need to look for individuals at risk for malnutrition, and then finally give thiamine. And just to add to that about giving the thiamine as early as possible and being comfortable doing it, very few downsides, very few adverse effects from thiamine administration. They were concerned about individuals developing anaphylaxis from administration of this medication. However, really low rates. We're talking about 1 in 250,000, if any, reactions. And also there was a series of 982 patients here in the US, in which only 4 individuals developed anaphylaxis. And only, none of those individuals developed anaphylaxis, and only 3 case reports in the last 40 years of people having anaphylactic reactions to thiamine administration. And with that, these are my sources, and there's more actually. Questions?
Yeah.
Yes. Miguel raises
You said any nystagmus, right? Like horizontal, vertical, rotary, any?
So any nystagmus or any ocular findings, you should have a higher index of suspicion, especially going back, as we said. I mean, exactly, the differential is still broad, right?
Alcohol intoxication itself.
Yes, and that's the problem with this, and this is why we miss so many of these cases, because there are confounding things such as alcohol intoxication or any other intox, right? We said PCP, someone called out. So you can have those ocular findings, but individuals with these findings and long-standing alcoholism, we know that they are poor in terms of their nutrition, right? So we need to have a higher index of suspicion and carefully evaluate them for this. Especially if we're admitting them, this is something that we should consider and maybe even just give them the high dose, right? Another thing is that any other individual with those findings and for risk factors for malnutrition, all I'm saying is that have this on your radar and consider thiamine administration. Yes?
I think, like, I try to add a little threshold because thiamine to just most alcoholics that come to the door. I mean, a lot of them might be, like, knocked out and might want to wait until they're ready to be awake and accept the medication. But I think EMS used to give thiamine, like, prophylactically, or they thought that they would say, like, acute Wernicke's, so they used to do it, but they don't anymore. And so I know after talking to Dr. Meir, he, like, usually gives thiamine to most of his alcoholics.
Yeah.
So
He gives high dose?
I don't know if he gives high dose, but he definitely gives IM. He don't give a PO or like a condition. If anything, it's probably just it's low risk and it's like good control like health.
Yeah, if you feel it's low risk, then the 100 is fine. But if you do have a suspicion for Wernicke's, you should be doing an intravenous 500. Anyone? Dr. Urensheimer?
Just the point you made about nystagmus. If you see vertical nystagmus, doesn't mean it's thiamine deficiency. There are other causes.
Correct.
But it usually means something pathological that's affecting the brain. For example, nystagmus from the ear is not going to give you vertical nystagmus. So you see that it's something bad, probably.
Yes.
You know, whether it's PCP or whether it's thiamine deficiency or whether it's cerebellar infarct. If you see it, you should be doing a further thinking.
Evaluation. Yes.
I'm going to just cautiously respond to Dr.
This is the last
comment. And in the ENT clinic with Dr. Hansen, who's the otoneurologist, he had a patient who had nystagmus and with DPVT. So it is possible. It depends on where that crystal
Yeah, you should have. I agree. Assume the worst if we see that, but it could be.
Rule it out. It's possible.
It could be a less benign diagnosis. All right. Any other questions? We do have to move on, unfortunately. All right. Thank you all.